Welcome back to another edition of the Hart2Heart podcast. My guest today is Dr. Matt Johnson, who's a professor of psychiatry at Johns Hopkins University and also a psychedelic drug researcher. So, Matt, welcome to the show.
Thanks, Mike. Happy to be with you.
Yeah, so I've known quite a bit about you for a while now. I've been following you on Twitter. I know you're making some big waves in the psychedelic industry, and obviously that's the subject that I wanted to ask you about today. But maybe before I get into some specific questions, can you give the audience a little bit of a brief background about yourself?
Yeah, so I have a PhD in experimental psychology with a focus on behavioral psychology, behavioral pharmacology, which is the study of psychoactive drugs. I've been at Hopkins for over 19 years now. So I've been doing psychedelic work for that entire time. So starting in 2004, outside of the psychedelic work, I've studied all the drugs, the uppers, downers, and all arounders, to quote Cheech and Chong, studies with cocaine and methamphetamine and alcohol, and lots of work with tobacco and a lot of other spattering of things, GHB and benzodiazepines. I could go on, opioids. So I've sort of been around the world in terms of studying psychoactive drugs and different lines of research. But a big part for the last 19 years has been psychedelics. It's where I spend most of my time now. A lot of work with psilocybin. I've done work in the past looking at effects in healthy normals, which is scientific code for people without a diagnosable disorder.
Because that's becoming more and more popular. Is that people are using psychedelics for obviously the treatment of treatment-resistant depression, PTSD, or sort of more classical mental health diagnoses. But at the same time, there is a lot of interest in people using psychedelics as a lot of people use the term a nootropic or nootropic. I've heard people use that term interchangeably. And so that's kind of interesting. But, the one thing that I said that really stuck out to me was that you started this in 2004. I mean, that is like, pioneer of pioneers, because, psychedelic research, we know there was, quite a bit done in the 60s and 70s. Then there was sort of like a big halt. No one really touched it for decades. And, most of the people, or most people that have gotten back into research, may have done it really over just the past 3, 4, maybe 5 years, that kind of thing. But you've kind of been doing this for 20 years. So how did you get involved in the psychedelic space like that early?
It was something that I wanted to research, going back to my early days in college, with this emerging interest in generally, the science of psychoactive substances and in behavioral psychology. And I became aware of, I did some research on the, just like class paper type stuff, on the older era of psychedelic research, which was really, it was not like folks, young folks today might not realize, like, this was not talked about. Like, you didn't come across news articles about this. If you came across anything about the therapeutic use of psychedelics, it was obscure. It's because you were going through, this is largely before the internet. The internet existed, but it was like text only. And, the early days, for folks that might remember Telnet and all this stuff, so for all, by what we mean today, like, the internet basically didn't exist. So it's like, you'd come across this older history, and only when you're pouring through books in the library, you'll come across, gosh, I remember reading Lester Grinspoon's work on psychedelics reconsidered, and books like this that you sit in the library or you check out from the college library.
And what did you think that psychedelics were able to treat back then in 2004? Because obviously today we feel that psychedelics and kind of research that indicates that it can treat a variety of different mental health conditions, including tobacco addiction, which is something that I do want to chat to you about, because I know you're involved in some research there with regards to psilocybin. But what were you specifically looking for in 2004?
Yeah, so I was interested generally and still am in psychedelics as behavior change agents. So to facilitating, broadly speaking, helping people with any number of disorders. It seemed credible given that earlier research and lots of anecdotes that this could be brought to bear on a number of things where um, people are people want to change. So the biggest example from the older research would be LSD in the treatment of alcoholism. Just seemed plausible that these psychedelics could instigate these what you could call aha moments, these big picture insights, sometimes kind of with a what the person may call a spiritual aspect, but not necessarily, but usually some sort of very big picture framing of the experience, whether it's in a religious or spiritual framework, or just someone feeling that they've just gotten this subjectively feeling that they've gotten this powerful insight into what's going on in their own mind, or even sometimes the nature of reality with philosophical thoughts. Not that we can that people having those experience is any scientific evidence that those experience are ground truth or not, but it seemed it seemed intriguing and likely that psychedelics could be brought to bear on helping with things like addiction. And I should say a lot of my research outside of psychedelics, in addition to just studying drugs broadly, a lot of my focus has also just been on the behavioral economics of disorders like addiction. So what is the decision making that underlies addiction? A lot of work on.
I want to ask you a little bit more about the alcohol, just because that's such a hot topic these days. A lot of people are trying to reduce their alcohol intake. It's kind of skyrocketed during COVID, unfortunately. Like we were chatting about before the show, I know you're at the psychedelic conference in Denver recently. I kind of wish I had went there now. But Andrew Huberman was there, and he put out a podcast. And I think it's been one of the most listened to podcasts like ever. And he was talking about reducing alcohol intake. And so what do you think has kind of sparked this interest in reducing alcohol intake in psychedelics? And
well, certainly there's that older research with LSD and alcoholism, which sparks the interest. I think you combine that that history with the potential anti-addiction efficacy effect of psychedelics with the sort of more of a modern well, to some degree continued recognition that alcoholism, or what the technical term in the medical and psychological field these days is alcohol use disorder, same thing, that that there's that there's problems that come in. People sometimes die, about 100,000 something along those lines of Americans die every year from alcoholism, and then there's and also consistent with what you were describing, consistent with Andrew Huberman's focus. The problems don't just come at those higher levels where we even would diagnose someone with alcohol use disorder or alcoholism. There's an increasing recognition that even levels, and frankly, levels that are even deemed safe, within the safe drinking guidelines of the U.S. government, seem pretty likely to be ones. Yeah, you're increasing your risk of cancer, and it's a graded effect. It's more akin to smoking than we would like to realize. Like, yeah, 20, a pack a day is really bad. One cigarette a day is a little bad. It's not good. It's way less bad than 20 a day. And so people should really view drinking, and I'm not a teetotaler. I try to keep things, in check and at a,
it seems like
at a lower level, but it is true when you're using it, you should recognize this is a little bit bad for me.
Yeah, like it seems like sort of what we recognize, like when I like a comparison to smoking, because if you say to someone, "Oh, I only have one cigarette a day or two cigarettes a day," they generally still acknowledge that, this is still bad for my health, but I know it's much less bad for my health than having, 20 cigarettes a day. Whereas with alcohol, we're now at a point where we recognize that, a small amount of alcohol is actually detrimental. So, a lot of people think, if I have 10 drinks, I know that's detrimental. But people will say, if I only have one or two, that's not really that detrimental. But in fact, it does have some, unintended consequences that, that we, could avoid if we just, zeroed out alcohol, completely. Again,
Right.
I like yourself, I'm not someone who's, zeroed out alcohol completely. Sometimes I still do have a couple drinks on the weekends, but I don't, touch it during the week, and I certainly don't get drunk by any means. So, it is something that I think, just like yourself, is kind of getting compared to smoking now. And I think that, we should compare it to smoking. And I think that, eventually people will start to realize that, drinking excessively, especially during teen years, can be very detrimental to the developing brain. Because, I've talked about cannabis obviously quite a bit on this podcast. So that's kind of what most people sort of listen to me for. And, we recognize that THC has a lot of harms on the developing brain, but we don't recognize that alcohol also has harms on the developing brain,
Right.
So something that I'm very happy that you brought that up. But just coming back though to the specific mechanism of action, I've always kind of wondered a little bit about this, and chat a little bit about, behavioral issues and why this happens in the first place as well, which kind of makes things, interesting, a little more complicated. But in terms of alcohol, like, is there a specific mechanism of action that is related to, say, psilocybin or to ketamine that is specific to reducing alcohol intake? Or is it just the kind of overall sense that, when I'm using these medicines, I already feel good, so I'm not really seeking a change. I'm not really seeking out alcohol to change the way that I feel. What is the exact mechanism behind these drugs, and why do they work so effectively for reducing alcohol intake?
So there doesn't appear to be a direct mechanism, and by that I mean there's no reason to think that that you're addressing alcoholism, for example, by it serving as a so-called agonist at GABA receptors. So much of addiction medicine, I'd say most, is, operates on this substitution or agonist model, meaning you are mimicking the effects of the problematic drug at the same receptor site that mediates the problematic drug, but in a safer way. So classic example, instead of shooting up heroin, someone could be on a methadone maintenance program. So, yes, you're kind of quelling the drug craving and reinforcement and withdrawal by, in a relatively speaking, safer way, giving the same, high, a milder, and ideally one just to, take the edge off the withdrawal, but not to get the person, intoxicated. And so, but that's the same basic principle behind all of the nicotine replacement, patch, gum, lozenge, and even whether it's approved or not, and it's not, e-cigarettes, which relatively speaking are certainly going to be safer than combustible cigarette smoking. So there's no reason to think that that's at play with psychedelics treating any addiction, alcohol, tobacco, you name it. And same thing with any of the other psychedelics. It doesn't appear that this is a direct mechanism in that sense. And another kind of argument in favor of that is most of these treatment models, and certainly the ones that have been studied under in clinical research, don't involve taking it on a chronic basis. Now, the whole microdosing thing, which is a different story, and again, that hasn't, especially in terms of the therapeutics, hasn't really been examined nearly at all.
That's an important point, though. So what you're saying that is with regards to decreasing alcohol intake and psilocybin specifically, it's more the macrodosing and not the microdosing that is shown to be effective in reducing intake. Is that correct?
Right. Well, there's really been no research on microdosing at all. I mean, other than some surveys. There's some research on microdosing in the lab in the double-blind conditions, but those studies, one, they haven't looked at therapeutics, and two, that have been published so far, they haven't. They actually also haven't shown even any hint of therapeutic effect in the basic mechanisms that are seen in the lab. Doesn't mean that there aren't real therapeutic effects with microdosing. The jury is just still out. My take is there's probably some kernel of evidence for some, probably best candidate being depression, but a lot of what we're seeing is placebo. I mean, I think everyone would agree that, well, not everyone, it's a strong statement, but the vast majority of professionals that know something about psychedelics, would agree that there's at least some placebo. I mean, there's some placebo effect in all of medicine. You want the placebo.
I mean, I always say that to people, like, if you look at any trial, I mean, sometimes even antibiotics, which is kind of crazy, that if you give someone a drug, whether it's a placebo, whether it's an actual pharmaceutical drug or a psychedelic, there's always some positive effect in the placebo group. I mean, obviously, when you have a very effective drug, the placebo, it was not going to be as effective. That's why we do these trials. But that just shows, the power of the mind and the power of the placebo. Like, if you take something and you think that it's going to make you feel better, generally speaking, it is going to provide some type of benefit. That's with, we have that's the one thing that's been studied more than anything in the world is placebo, because it's a double-blind randomized controlled trial. So yeah, I mean, obviously I agree with you as well that there's going to be some placebo effect to it, but it doesn't necessarily mean that the drug is not working. And I very, very strongly believe that the drugs are going to work. And with the microdosing, versus the macrodosing, I'm in the camp anyway, maybe I'm wrong, but I'm in the camp that microdosing just hasn't caught up to macrodosing in terms of research. And I do believe that there probably is some certain specific benefits to macrodosing over microdosing for sure. But I do think that once the microdosing research catches up, it'll also show some significant benefit, just potentially different benefits in different situations.
Yeah. And I think that for example, like, my speculation would be even within depression, there's the potential to even and this is consistent with some of the microdosing research that, like, you should expect a little increase in anxiety if you take a little tiny dose of a psychedelic. Kind of makes sense, because if you take a big dose, on average, you're going to get a big increase in anxiety, at least a decent portion of the time. And so it shouldn't shock anyone at all. And so, perhaps it's, if there is some efficacy for depression, perhaps it's best in folks with depression without, obviously there's a huge comorbidity, but not, there's variation there. There's some people it's primarily depression and anxiety really isn't the issue, perhaps for that population. The other stuff, like the ADHD drug, the sort of the creativity, the staying on task, that's, I wouldn't make any strong bets, but like, I want to see the results. It all needs to be tested. But the vast majority of what we know is about these what you could call macrodosing models or heroic dosing models, or what is technically really referred to as psychedelic therapy, which that expression specifically refers to using a very high dose of a psychedelic in one or a few instances to have this overwhelming response, to have this sort of psychological change. And so, so that's the reason, the reason that we know this isn't a direct pharmacological effect in some sense is that, like, that doesn't make sense if you take it like once and then you're seeing some effect 6 months later. There's potential reasons, like there could theoretically be epigenetic changes that could mediate the effect, and most of the simple, like, direct pharmacological explanations don't hold up. So it's really about, I think ultimately we're going to come to find, and I put this out there in various opinion pieces, is that the the effects that we see with psychedelic therapy are more akin and are underpinned by the same mechanisms as psychotherapy, without drugs. It's more similar to good behavioral or psychotherapy than it is to traditional psychiatric medications and even to life events.
One question I have for you on that. So, you're kind of saying that a lot of the effects that people are getting out of the psychedelics, more or less can be achieved with therapy. And also that when you use psychedelics with therapy, you can oftentimes people report that they can go deeper and that they have, much kind of prolonged conversations. And also they bring up things that they wouldn't necessarily, bring up before. So, that being said, like, what do you make of then, say, something like MDMA versus psilocybin? Because with MDMA, I would find that it would be a lot easier to do talk therapy on MDMA versus, say, if you did talk therapy on like a macrodose of mushrooms, right, or psilocybin. Because if you do, a low to medium dose of MDMA, it's very easy for people to be able to still be present. I mean, it increases that. It increases feelings of empathy. Is you want to talk. But with psilocybin, oftentimes people sort of get, so they have such a strong psychedelic experience that they're not really able to communicate too much. So with that being said, would you then feel that you would get more out of MDA therapy because there would be more time of time to actually spend with the medicine, as opposed to when you're not using MDMA or using psilocybin, you don't really get too much time to actually talk. Is that
not necessarily? I mean, I certainly understand the premise, but the talking during the therapy, during the actual session itself, during the psychedelic administration session itself, is not the only therapy. So yes, there is more talking during, really just kind of naturalistically, it fits with the drug effect. People kind of want to talk. I mean, MDMA has stimulant properties. That's one of the things that stimulants tend to make people do is yap. And so MDMA has this interesting effect, even just sort of naturalistically, even without encouraging it. People will give voice, so to speak, to when they're reliving trauma and processing trauma, thinking about, they're going to be spending some degree of the time talking about it with the therapist, sort of. And my impression from the MDMA PTSD work with the MAPS group, that about half the time is spent sort of introspective, half the time is spent talking. And as you described, talking is less likely with psychedelics. It's hard to get something out intelligible oftentimes. And so the advice is typically in psychedelic therapy with the classic psychedelics is collect experiences, put your keen intellect on hold for today, give it a day pass. I say give it a day pass in Baltimore. Maybe it's going to go to the museums. This is all metaphor, obviously, but then at the end of the day, reunite with your intellectual side, your descriptive side, and all that. But during the experience, just absorb the experiences, try not to describe it and talk, So I think, but in the psychedelic, in those with psilocybin, all the therapy beforehand, the discussion about the intention and what, how to navigate the experience, and discussion of the clinical issue itself, be it smoking, be it depression, be it alcohol use disorder, and then the so-called integration, which is really just discussing the session and what it may mean, reflective listening, helping the person hopefully process how the session might be brought to bear on addressing their psychiatric issues. That's after, before and after the session. So just because there's less talking during the psilocybin session doesn't mean that therapy is less relevant. It's just a different form of it. There's a huge overlap, obviously, but that's one difference. That's a very
good point, though, that you're making, is that you're basically coming, you're doing some therapy before that would allow you, when you have this massive psychedelic experience, to then still have like a tremendous therapeutic benefit from just having the therapy, like the pre-therapy, we can call it, does that mean allow you to go into the deeper spaces that you wouldn't have gone to otherwise? So meaning that, if you didn't have that pre-therapy, maybe you didn't, think about a certain way with regards to your depression or PTSD or anxiety, but because you've done that therapy, then it allows you to then, explore these situations a little bit differently and then potentially get more out of it. So that's actually a very, very good point, because, I didn't hear someone say like, don't do it at all, but I know that when Dr. Andrew Huber was talking to Ron Hart2Heart recently, that was kind of one thing that they discussed, is that, you want to do a little bit of talk therapy, but, if you're going to be doing like a heroic dose of mushrooms, for at least for a couple hours, like there's going to be very, very little talk therapy, because you're just going to have such a strong psychedelic experience. You're not going to be able to, have that. But that doesn't mean that you're still not getting benefits. And also it doesn't mean that potentially once you start to wear off, like maybe after, hour 2, maybe hour 3, maybe then you can engage in talk therapy when, the psychedelic experience kind of lessens overall. And again, we're talking about like massive, macrodosing right now, and you can certainly do talk therapy on microdosing psilocybin mushrooms, but I don't think there's any evidence right now that we can say that that's effective. But I imagine that once the evidence does come out where it is studied, we can say that. But right now, I guess it's at a point where you haven't really done too much studying on microdosing and therapy.
Yeah, there's essentially zero research on how to do psychedelic therapy. Basically, any control you will find to 99%, there's a few very minor exceptions, but is about the drug itself. So a placebo or randomized comparison condition, something. It's not about, with this same drug therapy, do we use this form of talk therapy? Do we use that form of talk therapy? Do we have even therapy, or not? Now I would say ethically, you need the minimal preparation to do it safely, regardless of efficacy. But you could have, just kind of standard, like 4 hours of preparation versus another group with this more extended preparation and integration. There's none of that. So along the lines of what you're saying, would it be better to say, maybe we will have, and this spontaneously happens to some degree, but like later, as you're describing, there is more talking in the afternoon, like 2 or 3 in the afternoon. The person was dosed around 8 or 9 in the morning, 2 or 3 in the afternoon. There tends to be more talking. It's not necessarily explicitly programmed in, but there's more kind of spontaneous talking. So the goal is to get as much introspection as possible. But there could be many different ways of doing this, and we're just totally in our infancy in terms of how to conduct psychedelic therapy.
Okay. So Matt, one question I really wanted to ask you today, because I think a lot of people are interested in this question in the psychedelic space, is do you think that there's one psychedelic that's emerging from one treatment over the other? Meaning that, do you believe that, there's going to be macrodosing of psilocybin, specifically for, say, tobacco addiction, where, say, if you had a treatment-resistant depression, maybe it would be more ketamine, or maybe if you had PTSD, it might be more MDMA. Like, is there something that you think that's emerging in the evidence, or do you think that it's kind of still way too early to decide, which psychedelic may be most beneficial for which specific treatment?
Well, it's certainly way too early to say anything with great confidence, because consistent with what I was saying earlier about, not really having any science surrounding optimizing psychedelic therapy itself, or comparing different psychotherapies that go along with the psychedelic administration. We also have pretty safe to say zero comparative pharmacology on these disorders, treatment of disorders across psychedelics. So, is MDMA or psilocybin better for PTSD or for depression? It's just for the large majority of these, only one compound has been used in clinical research. So myself and several others are very interested in our starting projects looking at psilocybin, for example, with PTSD. Obviously, the work in MDMA and PTSD is very advanced. It's the most advanced, unless you count ketamine, it's the most advanced in psychedelic therapeutics, with 2 phase 3 trials being completed, and therefore potentially within the next year or so it could be approved for that indication. But I gave a talk at this a Miami meeting in the fall around psychedelics, of what I called the generalized, think what I call is the generalized psychedelic therapy model, one specifically addressing this. My best guess, based on threads of evidence, nothing's definitive because the work hasn't been done, but I actually have some survey data that can speak to it. There, by and large, there are no specific differences amongst these various psychedelics and amongst the various disorders. So in other words, you could almost remember the like game Mad Libs. I don't know if it's still popular these days. It's like you give a random verb, a random adverb, a random adjective, and you put them together, you come up. Yeah, those are like hella fun, like little kids. But you could do that with okay, name the random psychedelic, LSD, name the random, one amongst these, group of disorders, be it anxiety, depression, PTSD, end of life, distress, fill in the blank. And I think if you do it right, now to be clear, again, we don't have the data yet to speak to that, but that's what I think is emerging. And I've done this. It's not published yet, but we're working on it. A large survey of people that use psychedelics explicitly for therapeutic intent. So I've done a lot of survey work with psychedelics. Most of it is just in people who have used psychedelics. In fact, I've published 3 papers with these kind of stories of people quitting addiction or substantially reducing the drug of abuse because of a psychedelic experience.
And one was psilocybin was with tobacco addiction. You've done quite a bit of work there, correct?
Yeah. So I've done quite a bit of work in the lab, but the survey work that I'm talking about has looked at psilocybin and others like LSD and others for the stories of people using those compounds and then they just spontaneously quit smoking. So as a point of contrast, compared to this newer survey work, that work, upper 90% of people across these various studies where people say they quit, cocaine, methamphetamine, opioids, cannabis, alcohol, tobacco, really, there's a lot of these stories in those various publications. They quit these or substantially reduced because they were just taking this, the psychedelic for fun or for exploration. It wasn't, oh, I'm going to address my alcoholism. I'm going to address what have you.
Also just came up.
Yeah, I mean, that makes sense because that's like why most people use. I often remind people the average person uses a psychedelic is like, a young person, their buddy scores some shrooms. You want to try this? They've seen cure things like, let's try it, explore. And it's neither like, life, the most significant event in their life, nor is it a hellacious, like horrible, bad trip. It's sort of like, maybe got a little anxious at times, but, they had fun. Maybe they watched movies, maybe they just goofed off. And that's kind of your more typical thing.
It's like when you say, it gives you what you need, not what you want. And so some people, maybe they're going into this with the intention of just having some fun and, that's all fine. But then during the experience, it comes up like, hey, you're drinking too much alcohol. Like, hey, smoking all that tobacco is really damaging your lungs. And then from there, they actually, start to look at their life and make changes and then actually quit those things. So it seems like it doesn't necessarily have to be the intention, like things can come up. And actually I heard Rogan say recently on a podcast, I'm not sure how she's like falls through with it particularly, and that's not a knock in any way, shape or form, but I know that he said that recently when he did some kind of psychedelic, I think it was mushrooms, that came up that he maybe was overindulging in drinking. I'm not sure exactly how he said it, but that's kind of what came up, but I don't think he went into that with that intention whatsoever. So it's kind of interesting that you're saying this, that people sort of, quote unquote, like, cure themselves without even trying to cure themselves, just that the mushroom or the medicine that they were using, kind of surfacing things that needed to be surfaced. And once they were surfaced, the person was able to deal with it, which is very interesting because, most people say you're, going into it with an intention. And I think there is that intention, but you might get struck by something else that, is actually much, much more powerful than your original intention.
Yeah. So and to be clear, I certainly strongly, think that your likelihood of having a therapeutic effect is drastically increased with that intention, and also with a, professional support, or just support of whatever type, if it's done well, to help you with that intention. But it's amazing that it ever happens spontaneously. But in contrast to that work, where the vast majority, people just took the thing for fun or for curiosity, etc., and they had these therapeutic type effects. This newer research that I've done is looking only at people that took a substance, whether it's one of the classic psychedelics like LSD, psilocybin, ayahuasca, or MDMA, for a therapeutic intent, and good, explicitly good, bad, and ugly, like whatever the outcome, because I want to know those. And actually, most, perhaps, very importantly, is neutral. It's like, again, like, yeah, you tried it and it neither made the thing worse and neither made it better, and it was just sort of like, I want those stories too. And so one of the and again, with the caveats, these aren't clinical trials, so it's not necessarily going to be reflective, but I think the strong trend so far is that, yeah, you can play the Mad Libs game, like in the people saying that it worked versus didn't is about the same across all of these, whether they took MDMA to treat depression or psilocybin to treat PTSD, or LSD to treat anxiety. Like, again, you could play Mad Libs, and it seems about those same rates of efficacy across. So that's consistent with that generalized, and that's totally consistent with the fact that we discussed earlier. It isn't this like that it's quelling your GABA receptors or your nicotinic acetylcholine receptors or your what have you, your dopaminergic receptors that mediate the stimulants. It's getting at deeper, certainly biologically based, and biology and psychology, in my view, are two sides of the same coin. It's not one or the other, but it's these more deeply seated. It's easier to describe as psychological, but most likely more deeply distributed throughout the brain. It's not going to be an easy story about, like, what's different a year from now. Probably those same biological changes that we don't normally look at in the field, that if you're successfully, helped with, you name it, depression, alcoholism, through psychotherapy, and there's strong science on this stuff and real efficacy there. Clearly, presumably, I think it's a very good assumption, but there's a difference in the brain, whether we have the ability to pick it up or not. I mean, presumably, think of a pink elephant, like something is happening biologically in your brain, whether we have the technology right now to understand it, that is at least a biological correlate. Whether it's a cause or the effect is that gets philosophical. You don't even need to go there. There's at least a correlate. And so, but we normally don't think about that, don't even think to ask the question, like, well, and you also don't get the skepticism, like, well, if they're helped a year later through psychotherapy, like, I'm not going to really believe it unless I know the exact biological mechanism that mediated it, right? But if we were talking about a psychedelic, we tend to think more that way. So yeah, I do think that there's this because of that general, you're increasing things like a flexibility in one's thinking, in one's personality, and openness in one's personality. This is work that I've shown early on, and healthy normals, and has been replicated.
It's just also too, like, they're just happier, and because they're happier, they just don't want to seek out these other substances anymore. That
seems to be part of it. In fact, that seems those so-called affective, in other words, emotional effects, show up in the treatment of, like in our smoking cessation work. In
the default mode network, like, is that specifically disrupted with 5-HT2A agonists? So, I mean, that's more or less the mechanism of action for most of these psychedelics. Again, they're different, and different ones are hitting different receptors, but it just seems that, like, that's the main one, that once you hit that one, there's some kind of like break. Like, what is exactly breaking up that default mode network?
I think we don't know enough I think the evidence suggests it's far more complicated than that. And Robin, who who pioneered the thinking on the that, hey, maybe that's a key mechanism. I mean, he's far more nuanced about it now as well. I mean, it's an understandable story. The idea that it's almost a little too it's a little too simple that should make us a scientist a bit skeptical in the long run. Well, it seems like these things for decades, going back to the 50s, folks said, oh, it seems like people report things like ego death and ego loss, and if you conceptualize the default mode network, and there's a lot of neuroscientists would like stop here and say, equating the default mode network with ego, like we know that the default mode network is more active when one is engaged in thinking about themselves in the past, personal memories, projecting them, thinking about what they'll do in the future. It may be another thing to kind of equate it to the Freudian construct of an ego, but nonetheless, so it makes a good story that, oh, the default mode network is disrupted, and that's the killing of the ego temporarily, and that mediates all these effects. But it's far more complicated. We know there's massive effects on brain network dynamics. In other words, the communication across different, which is what this default mode network finding refers to, this change in communication patterns across. It's not about the activation or deactivation of certain areas. It's about the synchronization of that activity or lack of activity across different areas of the brain. So those are the networks. We know that there's massive changes in network activity in terms of a global increase in connectivity. Areas that don't normally synchronize are all of a sudden synchronizing more, which is probably a proxy for communication if they're synchronized.
So,
but then at the expense of
mode network, maybe just give people a little bit of a background about what exactly that is and why we should care about it, and how psychedelics may be affecting it and affecting it in a way that's positive for people.
It's certain areas of the prefrontal cortex and the posterior cingulate are kind of the main hubs of it, but it's a group, and there's differences in opinion about what individual units fully constituted, but those are some of the main hubs of this these several areas of the brain, some of which are, it's not necessarily that they're all next to each other, but they're to some degree distributed. The activity of those things, you're going to see more synchronization across those areas when, for example, you say, oh, think about something you did in the past.
Will connect with areas that they weren't connecting with before. Is that correct?
There's more activity, there's more synchronization, correlation of the activity, which presumably means that there's more communication amongst the pathways connecting those. So if that's what you mean by, those areas being connected.
Is that where the creativity may play a role? Is that you're connecting different pathways, and you're connecting different pathways that weren't connected before, you enhance creativity? Is that sort of the at least idea behind it?
Very theoretically, we don't really know that, but I think that's very plausible. That's likely to be the case. Again, not necessarily the default, but just widely distributed. The knocks on sort of the default mode network as the key mechanism is that we know a number of local networks. I said there was that increase in communication globally across a number of areas, but that's at the expense of a decrease in local network activity. The default mode network is simply one of multiple of those. There's also a salience network that can, and some that can be decoupled. And so in some analyses, the default mode network isn't even the strongest example of decoupling. And so it may be just one example out of this massive change throughout the brains. And the other thing
to break up addiction, though, what do you need to break up that default mode network? Like, isn't that what is the mechanism behind why all these people are able to quit some of these medicines? Is that
we don't know that it's specific to the default mode network. I mean, certainly we know that prefrontal areas play a major role in addiction, exerting top-down control, but there's a variety of different connections and communication patterns across the brain. The other big kind of knock early on, the first thing that came to my mind as a behavioral pharmacologist that studies different drugs, it's like, oh, what do the other drugs do? and it didn't take much time to figure out, oh, there's here goes a study saying alcohol disrupts the default mode network. Here goes a study saying amphetamine does. Here goes a study saying THC does. We did some work. It found salvinorin, which certainly not a classic psychedelic. Some people say it's, it's a kappa opioid agonist, but certainly if you call it psychedelic, it's very different than the other ones, but it does the same thing. And so it seems like a lot of different drugs will disrupt the default mode network, which should be a major red flag into assigning any special property
that's very, very important. So you're saying
it may be that
alcohol can potentially disrupt the default mode network.
Oh, it does. Yeah.
Yeah. Okay.
So like we should, I mean, again, the story I think took off so quickly, and it's still like, I think for the public, like a lot of people think, oh, we've discovered the mechanism by which,
because people are like, oh, I'm just defaulting to this network all the time. I'm just continuing doing these habits. But if I take this drug that's going to, disrupt my default mode network, then I can potentially engage in new habits and not engage my old habits. But it doesn't seem to be that simple whatsoever. I'm not saying default mode network is not involved at all, but it doesn't seem to be, that simple. We're still kind of teasing out.
And that explanation sort of assumes that all default or habitual, you might say, activity, it's the default mode responsible. No, I mean, that's just, I think, a conflation due to language. It's like, there are, very much so to, addiction and depression involves habitual. I mean, that is the problem, or you could say default or habitual patterns that you want to break. It doesn't mean it's like the default mode network just because default is in the name. It's just, someone named it like it just because that's what's happening when people aren't on task, and so it doesn't mean that is the brain. These are the brain areas or the pattern of brain activity responsible for all habitual activity. So I think for a lot of these reasons, it kind of took off. And it may be, something like this. It may be far less sexy and exciting, the sense that, if all these different drugs disrupt the default mode network, the default mode network might be more of a signal of, oh, I just don't feel like my normal self. It's very kind of highfalutin to think it's, perhaps identical to, ego loss and everything that entails, the mystical experience and all the transcendental experience, all of this. But, you all, given what we know about the default mode network, the disruption of it may kind of, again, go along with just not feeling like yourself. But the same way, if you're flying on, amphetamine or stimulant or cocaine or really drunk, you don't feel like you feel different than normal, like that, which is a far less it's always, not uniquely psychedelic.
It's always hard to describe that feeling because I do prescribe ketamine in my practice. And, people always ask, what does it feel like? And it's always so difficult to describe because it's like someone asking, like, what does it feel like to smoke weed, or what does it feel like to drink alcohol? And you say, oh, I feel a little bit better. I feel a little more relaxed. Like, you can't really tell them like exactly how that feeling is. So for the most part, I just tell people that's very, very dissociative, which I think is, the most accurate we can get. But again, fairly subjective and still doesn't, give people the exact, it's not going to tell people exactly how they're going to feel. But one thing I wanted to chat with you about is antidepressants as well. So, some people, they do take antidepressants and they do feel better, and I know that, in the psychedelic world, antidepressants are sort of shunned in some circles anyway, because, they're like, we need to get away from SSRIs or selective serotonin reuptake inhibitors and, just use psychedelics. But do you feel that there still is a place for SSRIs, and do you feel that some people may actually do better with an SSRI versus a psychedelic?
Oh, for sure. I've always, in my work in this area, have tried to emphasize, I just want more tools in the toolbox. I'm not trying to take them away. I do think that certain classes of drugs are overused for a lot of reasons. We can get in, SSRIs being one, certainly the ADHD drugs overused. But I don't want them like removed from the toolbox. Like some people, and I think there's better ways to use these things. For example, for depression, like the original intention, it's like, okay, you're so depressed. And originally when this stuff was being worked out in the 50s and 60s, What we meant by depression there was different than we meant by depression today. It was typically much more severe. Stuff that's labeled depression today wouldn't have been labeled depression then. But okay, you're so so depressed you can't get out of bed, you're not interacting with friends anymore, you're becoming increasingly isolated, like the whether it's the SSRIs from the 80s onward or the more original MAOI tricyclics going back to the 50s, works the same basic mechanism of augmenting serotonin and in some cases other monoamines, the extracellular transmission of these monoamine neurotransmitters. It's giving you a window. Now you can get out of bed. Now do some changes in your life.
Yeah.
To now that window's open up, and you're not going to stay on that antidepressant forever. You're going to use that as a window. And so I still think today, and obviously, as you know, they're rarely used like that.
Said, though, I gotta just rewind that for a sec, Dr. Johnson, because what you just said is really important. A lot of people are so depressed that they can't exercise, and I totally get like people who are saying like, I'm sick of people telling me to exercise because I'm too depressed to exercise. But what we can do is potentially, get you on a medicine,
yes,
that can potentially get you that feeling that you can exercise. But the thing is that you need to capitalize on that energy. That's why I tell people all the time, when you're really depressed, you don't feel like going out. Sometimes, you may not feel like even getting out of bed. For some people,
or eating healthier options.
Yeah, eating healthier options.
Or being social,
being social.
And then you just go further into or to drink less, or we could go on and on.
Yeah,
like when you're in that well.
Some people don't have sex when they're
yes.
And so once you start feeling that energy, then it's on you to capitalize on it. Like for sure, it's on us as physicians to try to find the right drug to give you that initial motivation. But once you get that initial motivation, it's really on the patient then to utilize that energy and to utilize this new state of mind to start trying new things and to kind of motivate yourself and get momentum. Because once you get momentum, it's a lot easier to keep than say to start or to initiate.
Right.
So when someone's working out 4 or 5 days a week, they're probably going to work out 4 or 5 days a week the next week just because they've got that momentum. If you're not doing anything at all, it's very, very difficult to initiate. So I'm so happy that you said that. And coming back to your point, some people might be surprised with this. I mean, even just recently, someone came to my office who was very depressed. I offered them ketamine, but I also said, we can try an SSRI, something that's a little more gentle, something that's not going to causing any dissociation, that kind of thing. And they responded extremely well. Like they said that it's the best they've felt in 3 to 4 years, which is amazing. And so I really agree with you that we don't need to throw out all the tools out of the toolbox. For some people, SSRIs are in fact effective. And again, I'm not shitting on everyone who's in a psychedelic space, but we do need to come back to what you're saying, that this is just another tool in the toolbox, and it's a tool that we shouldn't be afraid to use. But also too, let's just not discard all of our other tools, because some of them are in fact benefiting a lot of people.
Yeah, and I think, to me, if I could make connected to a larger point that I think this is a subset of, that there's just a lot of, frankly, puritanism, is that the excuse my grammar, I think puritanism might be the right way to say that, and authoritarianism in the psychedelic, and not just maybe the same as people in general, maybe even a little more so, because you get this religious vibe. Like once people have this one of these experiences, they think, this is the thing that can solve everything. And
I can't got it right away. If someone, I always know, like I can tell,
like, first ayahuasca experience a month ago.
This is gonna change your life. It's like, I know you did that like 1 week ago. Because 6 months, I don't know if you're gonna have the exact same feelings right now. So you do have to be really careful about beginners telling you about their first experience, because they're going to tell you that it's going to change the way you feel. You're never going to have to feel depressed ever again. Everything in your life's going to be beautiful. But it's just that it's not that easy. It's just that you just had your first experience. But let's see how time unfolds and how you feel over time.
and you see this kind of purist thinking, this kind of religious thinking across a lot of domains. Like, so for example, the work with non-psychedelic analogs, it's like, I think, I've got a lot of thoughts about that. I think if these things, have therapeutic effects.
What that is to people.
So these are modifications, and we know several exist, and companies are working on making new ones. Compounds that are molecular tweaks of existing psychedelics that have no or substantially less psychoactive effect, that are still inducing the same neuroplastic effects that we know. We're not certain they happen in humans, but these neuroplastic effects happen from psychedelics. We confidently know that they happen in animals, in rats, for example. And so there's the possibility, I think likely that's at least part. I don't think it's the whole thing. I think there's a lot going on with psychedelics explaining their efficacy, but that's probably, decent bet that it's part of the therapeutic effects we're seeing in humans. But it's like, we can harness that, just the pure neuroplastic aspect, to maybe make you more temporarily flexible in your thinking and your thoughts. I think if there's efficacy there, and I think there's a good potential that there can be efficacy there, I think it should be explored. It's not heresy.
Yeah,
a lot of people would never qualify for psychedelic model. A lot of people would never be attracted to it. And even for the people that do it, like, we might find out that the best treatment is for those that qualify and want it, have a big psilocybin session or MDMA or whatever. And then, every day for the next 3 weeks, take one of these non-psychedelic analogs to extend a window of neuroplasticity that bumpy might, so it's like this either or thinking, like they could be combined. It could help people that would never. It's like, again, I just want more tools in the toolbox. And there's just a lot of this kind of religious zealotry, if you will. Like, I had have a protocol approved to see if psilocybin can help people with opioid addiction. And this is helping people with methadone maintenance who are on methadone. And there's lots of strong opinions about that, no, well, what do you mean? The goal isn't to get them off of methadone. No, it's for people still using illicit opioids and cocaine. And so to kind of stay on their program, their methadone. And it's easy to come in from the outside and just kind of totally, vilify methadone. But if you know the science, early on, when the idea was only to have it temporarily and to pull off from people from methadone, like, then you get a lot of lethal overdoses and people who were all of a sudden able to maintain a job and their family connections and all these, and not catch hepatitis and HIV and all these other things. But yet, because of this puritanical thinking, I've got to get off of methadone because I'm still addicted to something. And then the person's dead because they've overdosed or they have some of those. So I'm not saying, a lot of people, if someone feels called to move off of methadone, I'm not saying that should ever happen, but the medical field had learned early on, it's like, be very cautious about prematurely pulling people off of methadone.
There's definitely some good indications to it. I mean, my fiance is an RN, and she works in a methadone clinic. And I mean, there are some people there who really benefit from that medicine. And if you do it properly, again, doing it properly is the main thing. You can, get off of opioids using methadone. I mean, we have plenty of success stories of people that do it. That's why those clinics exist. It's just that it's only a tool. It's not that, like, if you get on methadone, you're definitely going to get off of opioids. It's just that it's going to make it a little bit easier for you.
Right. And people still struggle. So we need to, with all of these things, I think there's just zealotry in the psychedelic field. I'm always a voice for, including just like a lot of preaching to people, like, you shouldn't do that. That's wrong. It's like, let the natural variability go. Let people have scientific debates. Let the evidence get out there. If someone feels inclined to pursue non-psychedelic analogs, let them do it. If you're skeptical, wait for the results. Let them see, like, maybe it won't work. People want to see that.
I'm very excited for these. I mean, I'm probably in the same camp as you too, that, like, I do think that having that, trip, so to speak, that psychedelic experience definitely is part of the therapeutic experience, but it may not be all of it. And, maybe you only can do, a psychedelic trip like once every 6 months or once every 12 months or whatever it is. But maybe you need some of these, non-psychedelic analogs during the time when you're not, tripping, in between
perhaps,
between those 12. Maybe that can make a gigantic difference. So, it doesn't sound like those drugs are being made to eliminate, the psychedelic experience, the psychedelic trip. And if they were, I certainly would be against that because I don't want that to be eliminated. Because, like, so they just said, I do think that is part of the therapeutic experience is the trip. But, if there's drugs that can, help in the meantime and be like a bridge until you have your next trip, I think that's fantastic overall. And, that's a perfect segue to what I was going to ask you and for my next question, because I know we're kind of over time here. So sorry if I'm taking up your time here.
No, we're good. Yeah, I can stay on here.
I want to ask you about, so unfortunately, a lot of people don't try psychedelics because they're already on antidepressants. And this is something that I think we should discuss because, a lot of people say that, if you're taking high doses of antidepressants, SSRIs, you don't want to take psilocybin because you're going to go into serotonin syndrome. And I do think that you have to be very, very careful about that. That being said, I have seen one published study, and I think there was a pre-treatment study too. I sent it to Hart2Heart actually on Twitter, and he did respond. That indicated, and it was escitalopram that was given. It was only for 2 weeks, I believe, which is not typical. Most people who are on escitalopram are on it for years, months when they want to try something. But it showed that the effects of psilocybin were still effective on these particular subjects who were taking escitalopram, and it actually showed that they had less negative side effects. And then there was another preprint. I know Kevin Pecker had tweeted out recently that indicated something roughly similar. So do you think that it is very dangerous right now for people who are on antidepressants to use these psychedelics? Just because those are the people who we want them to use. Like, those are the people who really need them, or it's the people that are already on these antidepressants, but they can't get off of them so that they can use these drugs. Like, do you see that being an issue, or do you feel that some of the science may be coming forward indicating that it is a little bit safe for people to use both these medicines?
I think the main concern with SSRIs and other traditional antidepressants is that you get a muted response to psychedelics because of the downregulation of the receptor systems that mediate the effects that, now, for example, you have less 2A receptors that are expressed, and therefore you have less of a psychedelic effect. So that's been shown in rats, where you're very confident about the causal effect, but it's also reports in people and published in the scientific literature, not short of clinical trial, but people, patients saying, oh, they used to trip with their friends, they always split the bag of mushrooms, and and it always had about the same effect, but now that they're on Prozac or what have you, now they barely feel anything, and all their other friends that take the same dose are having the typical psychedelic experience that they would have, and so actually with those, with most antidepressants, the concern is not serotonin syndrome. It's not having an effect, and therefore not having a therapeutic effect. More of a concern with things like ayahuasca, which has MAO inhibitors in it, that could adversely affect any number of medications, such as SSRIs. So that's kind of more of a concern there. But it, and there may be variation across some of these antidepressants, so we just need more explicit research. But it may be that in terms of that more attenuated effect I mentioned, it may be that in the future we could just do the parametric research to figure out that, oh, you simply need, and I'll make up numbers, maybe you need twice the dose to overcome that downregulation, or 3 times the dose, or 20%, we don't know. So there's a lot of, but that's going to be a very important thing, and thing to work on in the future, because it's tough to, a lot of people are on, and I could tell you from doing multiple studies with depression and psychedelics, like a lot of people are saying they've been taking this antidepressant for years. They have no idea whether it's working. Like I just keep taking it. I have no idea whether I get, and so it might still be helping them, or they just might be taking this thing that it's like, it doesn't work. Maybe it helped them at the beginning, but now it's sort of irrelevant. They don't know. And so they might be in the category, oh, if I have to go off for the study, I'll go off because I'm not convinced I never had a reason to go off. And my doctor says, if you're doing okay, just keep taking it. But it's a tough thing for people to do, because there is a concern. Oh, what if, theoretically, what if it was helping and they go off and now they're suicidal when they weren't?
There's a couple of people recently on Rogan. One was Theo Vaughn, and the other one was the guy from Deal or No Deal, Howie Mandel.
Okay.
They both kind of said, I know that Theo Vaughn specifically said that he's taking escitalopram, which I just want to briefly ask. I know you don't have too much time here left. But he said that, he would like to try ayahuasca, for instance, because I think he said he did it once and it was helpful for him. But he said, just coming off of, the escitalopram for 30 days would be pretty tricky for him, And then I think he wasn't as forthcoming with what he was taking, but he basically just kind of indicated that, he would have to go through a lot of withdrawals from his other medicines in order to, get on it. But it seems like, and again, we're certainly not advocating on to take both these medicines at the same time, but it seems like some of the literature and from what you're saying today is that it may not necessarily be that it's overly dangerous, although it can be, particularly if you're using like an MRI, say with ayahuasca, right. But it's just that the therapeutic effect may be significantly less. So for some of these people, maybe they can have, a good psychedelic experience, but we'll need to figure out what doses is specifically for them. And it's probably going to be different doses for different people. Like if you're taking, 40 milligrams of, escitalopram for 20 years, that's a lot different than someone taking, 10 milligrams for, 2 weeks or even for 2 months. So, interesting thing that we need to tease out there. So, very last question here, I promise. I know I'm taking up more time than I asked, but with regards to SSRIs, like, has one more or less emerged as the best one for you, or do you kind of recommend one? Because I'll be honest, I sort of have gravitated a little bit more towards escitalopram, because I've seen a couple studies indicating that was superior to other antidepressants when they've looked at them. So just wondering what your thoughts are on that, or if there's one that you think would be best overall.
Really no opinion. I'd defer to your expertise on that. I mean, I know, something about depression, but I'm not a clinician. I'm not a physician. I'm an experimental psychologist. So, a lot of what I know about SSRIs and other antidepressants are, my expertise in psychedelic or psychoactive drugs in general. But in terms of a nuanced questions like that, I'm not, I don't have anything to offer. But and a lot of this I could imagine, especially differences, because there's not a lot of, in general, I'm not saying there's any, but just there's very little incentive to do comparative studies. It's like, right. Hey, your thing works better than placebo, you can get it approved. And it's like, you kind of don't want your drug compared to something like, what if it doesn't look as good? And then people won't, so, a lot of we need to like really track what research there is. But then a lot of this also comes from just on the ground is, it's like clinical experience, where individual, clinicians, notice, and then, traits.
That's a good point. Not to go off too much on a tangent, but I had someone on my podcast recently, and he went over what evidence-based medicine was. And, he kind of schooled me a little bit on it, because to me, I said, it's applying, the best practices, meaning, taking the best evidence from PubMed trials and randomized controlled trials, meta-analysis, and, applying that to your practice. But, he said actually, a third of that is clinical expertise, and so, we don't need to, we can't discount that, like clinical right. expertise is very, very, important. If you do see one, antidepressant working better than another, I mean, that is something that, you should potentially hold on to and think about and use that, going forward. Right. But I know I've, taken up so much of your time already, and I'd love to have you back on the show someday, because there are some other questions I'd like to ask you about, particularly with psilocybin mask versus no mask, and in the darkness and not in the darkness. But we'll get into that maybe another day. But can you tell people where they can find you on Twitter, when they can learn more about you and your work?
Yeah, on Twitter, drug_researcher is my handle. So yeah, if folks want to follow me, you can find me there. That's probably the best place to find me.
Awesome. Well, thank you so much for doing this. I really had a great time chatting with today. And for everyone listening, I'll be back again with another episode soon. And so thanks to everyone listening, and we'll be back soon.
Thanks, Mike.
Awesome.
Cool. Yeah. Great conversation. Yeah, good topics.
I really enjoyed it. And I wish I'd gone to that psychedelic conference now. It seems like everyone was there. Did you have a good time?
Yeah, I left like a day and a half early. So I didn't see the whole thing, including like there was a big protest at the end, which is just honestly a shit show. Like just
really?
Oh yeah, you can find it on Twitter, man. But like Rick Doblin was giving his final address, and so you have thousands of people there, and this thing was like a stadium. Thousands, I don't know how many people were in that room, like 5,000 at least, I'd imagine. Anyone who stayed to the end of the conference probably maybe it was more like 10 plus thousand. I don't know, but it was a huge thing. And like, Rick, it's like, it's the end, the final closing remarks, and just a group of kind of 5 people came up drumming, disrupting things, and saying that it's like this is like classic, like there were no demands, there were no specific complaints. This very general, like not enough attention towards indigenous communities. And honestly, that's like, there were more indigenous talks and shamanistic talks than any psychedelic meeting I've ever been to. And I've been to dozens over my career. And, just a lot of talk of colonization and appropriating plant like medicine. And, it's like, MAPS, it's like, they're the ones running it. It's like, their thing is MDMA for PTSD. It's like that's been used by no indigenous, at least traditionally by indigenous communities. And, they were, part nonprofit, part, going for, the social benefit corporate. So it's just like, what's the, it was just this general, and like, it was sad. And then he eventually relented and let them up on stage, and he gave them 1 minute, and they took whatever 10 minutes, and it started out really angry, and it was kind of a shit show. And it's just like, my God, it's like you could spend like 40 years building something, and it's just so easy to tear things down. I mean, you're just seeing so much of that in this kind of like radical, like, I don't know, just this super woke, like you can come up with
to be first, and everyone wants to be best, and everyone wants to listen to them, kind of thing. And it's not supposed to be about that. It's supposed to be all of us like kind of coming together and experiencing this on their own and improving mental health. But I've already experienced that in the cannabis industry, and I can see it now a little bit in the psychedelic space. I think it's just the way humans are, unfortunately. But
yeah, it's getting interesting, and it's a little concerning going forward, because people are, there's already been like, oh, MAPS is supporting white supremacy because they're treating vets. It's like, oh, it's just, it's just like, like the Symposia group. I mean, this is like, I'm not trying to ruffle feathers. I won't talk about this on the podcast, but like, I was like, oh my God, they're full on want the communist revolution. Anyone who's like, doing any business surrounding this stuff, it's like the pitchforks are up. It's so unhinged, some of this stuff. So, and like, it's getting crazy but you should check out if you're curious, like maybe you should avoid it for your own psychological health. I don't know. But if you're curious, like a car accident.
It is. But okay, brother. So just regards to the episode, I'll try and get it out over the next day or two, and then I usually break it up into like a few different clips. So I'll tag you on the clips and all that kind of stuff. And
sure, I'd be happy to like retweet it and whatnot, and like hopefully awesome.
I would so appreciate
generate that. Some. Yeah.
And
very cool.
And yeah, you got my email now. So anytime you want to reach out for any reason, let me know. I'll be happy to chat further with you. But really appreciate you doing this here today. It means a lot.
Yeah, thanks, Mike. Yeah, happy to do it, and happy to do it again. And yeah, again, great questions, great conversation. Appreciate it.
Okay. All right, brother. Well, we'll chat again soon.
All right. Take care, man. Bye.